Hi, and welcome to the Restorative Wellness Clinicians Corner, video series exclusively for functional health professionals, where we interview the top experts in the latest research, products, tools, and best practices for getting your clients exceptional results. Hello, my friends. Well, today's episode is truly incredible, and you are in for such a treat. We talk with Dr. Nancy O'Hara all about one of the most challenging neurological conditions that affect children, PANS, or Pediatric Acute Onset Neuropsychiatric Syndrome. This is an invaluable episode for anybody who has children, who works with children, or who works with parents of children. Whether or not you want to actually work with the children who are suffering with PANS, you're going to want to listen in because you'll get to hear what to watch for, because it's not uncommon for the parents to be really panicking, watching their children struggle so much, so quickly, seemingly out of nowhere, and then to have so much trouble getting good medical support. So if you know what to be listening for, you can play a role either in supporting their process clinically or in helping direct them to great resources. Before we get into the interview itself, I've got to tell you a bit of the backstory. I met Dr. Nancy O'Hara at TFIM. That's the Forum for Integrative Medicine. It's a conference I was at earlier this year. And I sat in on her lecture on PANS and Pandas. I loved what she had to say. And I went up to her immediately afterwards, asked if she would be willing to come here and chat with me as a guest on this podcast. And I was delighted that she agreed. We got her on the calendar, all was set. Now, usually when it's a practitioner that I've just met briefly like this and that I don't know personally, I usually set up a little time to chat before the interview and cover the kinds of questions I'm going to ask, make sure it's a good fit, that their thinking aligns with our thinking. But in this case, it's over the summer. It's been a very busy summer, and I will admit I just completely forgot. This slipped through the cracks. Suddenly, it's a week before the interview. My schedule is completely packed, and we have no time to connect. So we talked for just 5 minutes before the interview, and then we just dove in, and I just trusted that this was all going to work out. And I've got to tell you, oh my goodness, it was amazing. Dr. O'Hara does not disappoint. And I had to laugh because I am quite positive some of my students are thinking to themselves as they're listening that I paid her to say some of what she did, because she highlighted some key points that are integral to our teaching at Restorative Wellness Solutions and that we are always emphasizing over and over again. I loved the interview. It was a fantastic conversation, and I think you will as well. Enjoy. Welcome, everybody. I am really, really excited for our conversation tonight, this episode of the RWS Clinicians Corner. We have a very special guest with us, Dr. Nancy O'Hara. Dr. Nancy O'Hara is a board-certified pediatrician. Prior to her medical career, she taught children with autism. She then graduated with highest honors from Bryn Mawr College as a member of the Alpha Omega Alpha Honor Society from the University of Pennsylvania School of Medicine. She earned a master's degree in public health from the University of Pittsburgh. After her residency, chief residency, and general pediatric fellowship at the University of Pittsburgh, Dr. O'Hara entered general private practice in 1993, and in 1998 began her consultative integrative practice solely for children with special needs. Since 1999, she has dedicated her functional medicine practice to the integrative and holistic care of children with chronic illness and neurodevelopmental disorders such as ADHD, Pandas and PANS, OCD, Lyme, and ASD. She is also a leader in the training of clinicians, lucky us, both in the United States and abroad. Dr. O'Hara has quite literally written the book on what we are going to be talking about tonight, on PANS and Pandas, Demystifying PANS and Pandas, a functional medicine desktop reference on basal ganglia encephalitis, which is available on Amazon and all the places. And I met Dr. O'Hara at TFIM, the Forum for Integrative medicine, I think.
I think
I'm
so.
never good with saying what the actual acronyms are. Earlier this year, and she gave an excellent lecture on this topic. And I immediately went up to her afterwards. I've been looking for somebody to really dig in deep on this such important, complicated from all the angles topic. And so I was so delighted to have her here with us. Dr. O'Hara, welcome.
Thank you so much. It's really good to be here.
I would love for you to share with our community a little bit about your story and what brought you to pediatrics, but specifically to working with these children and families struggling with PANS and PANDAS, which is just such a challenging situation.
Yeah. I mean, my story sort of starts in Wheeling, West Virginia, where I grew up, to two parents who were both conventionally trained physicians, general practitioners, but they were the type of general practitioners where we got paid in chickens and steaks and protection from the mafia. That's a separate story. But after medical school, residency, and all those things you mentioned, I was teaching. I was a partner in a pediatric practice. And because I had taught children with autism before I went to medical school, I had a lot of kids in my practice with autism. And it was actually some of those moms that said, if you ever do anything differently, we need somebody to integrate all of our care. And I thought, well, maybe, I don't know. But then one of those moms, their child, they went away on vacation. Their child got a diarrheal illness. She called the nurse at the office, and the nurse said, well, take him off dairy because the dairy is probably exacerbating the diarrhea. Now, he was 4.5, had never spoken, had autism, allergies, asthma. I'd been trying to get him off dairy for years, but mom couldn't see a way to do it. She was a full-time working mom. Anyway, she took him off dairy and he started talking. She called me and I said, well, you're on vacation, you're working with him. Now it's not the dairy, call me when you get home. Came home, got over the illness, put him back on dairy, stopped talking. She called me and I said, well, it's the transition, thank goodness she didn't listen to me. And she tried it a few times over the next few months. And then she went to meet my mentor, Dr. Sidney Baker, who is the grandfather of functional medicine. And she came back to me and she said, there's something to this diet, nutrition, and the brain. And I thought, well, this is crazy. But at the time, I was going through 5 years of infertility. So I went to sit as a patient because I couldn't wrap my head around this yet as a, tried and true conventional MD. And it changed my life. I treated my yeast, I changed my diet, I detoxified, I did all the things we talk about all the time, and did craniosacral therapy, et cetera, et cetera, et cetera. You name it, I did it. And a few months later, I was pregnant. And at that time, I thought, I tried to integrate it into my regular practice and just couldn't make it work. A week before I quit, my partner said, you're not making enough money, you're taking too much time with patients, and all the other things I wasn't giving, that conventional doctors do. So started out on my own. Fast forward 10 years, my neurotypical lovely son gets a strep throat. The same week, he gets a viral infection, gets bit by a Lyme-positive tick, and devolves into seizure-like tics. And thankfully, because I had spent all this time learning about functional medicine, I treated him, and within 3 months, he was back to himself. And I thought I had treated it all until 5 years later, he developed the striae of Bartonella and started treating the Bartonella, and all of the symptoms, the tics, the OCD, the anxiety came raging back. But what was very interesting to me is after we got all that taken care of and the Bartonella was treated, then everything, including his need for a 504, accommodations, ADHD, all of that went away. So that was my introduction into PANS Pandas. And now, rather than being, 80% children with autism, 20% with pandas, I'm about 99% PANS, PANDAS, basal ganglion encephalitis from mold, tick-borne disease, anything. And that's what my passion is, and that's what I'm trying to teach. So anyway.
Well, thank goodness for you because these parents don't have a lot of good resources. And I love your mission of really trying to equip as many other practitioners with these tools that you have. And you just so generously, I just really want to give a plug for this, for your book. I mean, you just so generously kind of like lay out the step by step, really, really helpful for practitioners and really helpful. I know that you believe so firmly this, in supporting the families going through this so that they understand how to navigate because it can be so hard. You've got these parents sort of knowing something is really off with their children and not getting answers, and needing to sort of play like quarterback. Maybe that's not the right term. I should never use football analogies, but they're having to they're having to navigate between all of these different medical professionals not getting answers. And so you're really equipping us all with some really invaluable resources. What I would love to do is start at the beginning and just help us understand and just define, so we're all on the same page, what is Pandas, the autoimmune basal ganglia encephalitis. I hear post-acute infectious syndrome. Like there's all this language that kind of gets thrown around. Can you help us kind of tease this apart and really understand and define what we're talking about here?
Absolutely. And I have to say, as a Steelers fanatic, I love football analogies. So, anybody wants to use them, I'm good with it. And yay, the Steelers won yesterday. So anyway, a nutritionist from Pittsburgh was getting on the plane, by the way, on our way to one of our conferences I just left. And she saw a terrible towel and she's in my membership, and she brought me the terrible towel to the conference for the game yesterday. But anyway, so in decades and decades ago, we used to have a lot of rheumatic fever, which is where strep, either untreated or undertreated, caused heart disease and other symptoms. And one of them neurologically was what's called Sydenham's chorea, which was large involuntary movements that a child could not control that was caused by the abnormal immune response from a strep infection attacking the brain. So in the 1990s, Sue Sweeto coined the phrase Pandas when she found that some children after a strep infection got very similar symptoms. So Pandas is pediatric autoimmune neuropsychiatric disorder associated with strep. Now, because she named it Pandas, and that's a very cute animal, it became, and she wasn't excuse me for being a little sexist right now, but she wasn't the typical male that named it after herself. I think she and I would agree that it remained a very controversial subject and syndrome. And so in 2011, a group of 30 clinicians and researchers got together and found that, yes, there were indeed other infections that also caused this. And they specifically talked about mycoplasma, viruses, and Lyme disease at the time, as well as other metabolic causes. One of the biggest, in my opinion, is mold, but certainly pesticides, anesthesia, and we also know many other toxins and chemicals in our environment and that we may inject that can also cause an acute change. So they put all of that together and called it pediatric abrupt onset neuropsychiatric syndrome, thinking that that would make it less controversial. And as we all know, it's even more controversial today. So much so that the more conventional experts in this disease really don't even include Lyme anymore because that has its own group of controversies. Now, a couple of things just about that definition. The P is for pediatric. But we now realize that this can often go long beyond pediatrics, and that young adults especially can have this disease. The second is the A in PANS is abrupt onset, but especially if the first occurrence is very early in life and maybe missed and maybe minor or mild, then the second occurrence may be more subacute and more severe, but it isn't recognized as the second because the first was kind of glossed over and treated easily. Or if it's Borrelia, Bartonella, Babesia, mold, it often is much more subacute. So those are two changes. But the idea is that a child has, after an infection or other trigger, a dramatic change or onset of OCD, or in 20%, a restrictive eating disorder.
Right.
And actually, since COVID, that number's gone up. In our practice alone, it's over 35%. And then two of these other syndromes. So it could be separation anxiety. That 9-year-old that used to leave mom's side, no problem, and go to school, now that is clinging to her, won't even go to another room in the house. It could be developmental regression. All of a sudden, the 11-year-old just wants to watch Thomas the Tank Engine videos or starts using baby talk. It's sensory or motor abnormalities. And the biggest one that's almost pathognomonic for this disorder is an abrupt handwriting change. Right. So if you're ever wondering or talking to a parent and they're not sure what's going on, ask them if the handwriting has changed. It can be when drawings in a 2-year-old or actual handwriting. And I do a lot of social media posts, and one of the ones that's coming up this week is on a dramatic handwriting change in one of my patients. And then it can also be emotional lability. I call it that 0 to 60. 1 minute they seem fine, and the next minute they're crying or raging, etc. And then somatic symptoms. And this again is almost pathognomonic. If you have one of those anxiety, tics, handwriting deterioration together with either an abrupt onset of bedwetting or urinary changes like frequency, urgency, or you have a sleep change, particularly what's called REM disinhibition. REM is that deep sleep, and if they're not getting into deep REM, they're very restless sleepers. You know, the sheets are all of a sudden all over the place. They're ending up on the other end of the mattress than what they started with. So if they have one of those two together with one of the signs, again, pretty pathognomonic for this disease. Now, we have to say that you got to rule out other things, but this is an autoimmune disease. So what's happening, let's take strep as the example. A child will get strep throat, and in a neurotypical child that doesn't have pandas, and they say it's about 1 in 200, it's about 1 in 1 in my practice, but 1 in 200, those that are genetically susceptible, rather than the antibodies or the proteins within the immune system attacking the strep in the throat, they instead cross the cribriform plate, cross the blood-brain barrier, and those antibodies, those proteins, attack a part of the brain called the basal ganglia. So why I titled my book or subtitled it Basal Ganglia Encephalitis is that's what it really is. Right. Whether you're talking about post-acute infectious syndromes or post-treatment Lyme disease or PANS or PANDAS, what's really happening is there's inflammation in that part of the brain that controls these movements, the anxiety, the OCD, etc. It's not the infection going in there. It's the immune system being dysregulated and that causing the inflammation in that part of the brain.
There's so much I want to unpack in here. So just to start off with, I think, as a parent myself and hearing some of these things, I think that, like with a lot of, when you kind of run through the list of things, you think, oh, well, my daughter didn't want to say goodbye the other day, or she didn't sleep very well a couple of nights last week. There can be things, I think but I want to really emphasize and see if you agree is that we're talking acute and severe and continued, not just meltdown this afternoon, but back to their normal selves the next day. We're talking, the sort of behavioral or these sort of disillusions, significant and ongoing and not correctable using the normal parenting strategies. Am I correct in understanding that?
Absolutely.
Okay.
And also a few things together. It's not like just OCD. There's got to be OCD and, urinary frequency or handwriting deterioration or sleep problems. It's OCD or the restrictive eating disorder and two of those other things I mentioned.
Got it. Now, then, and it really, in terms of the type of infection, of course, with Pandas was in thinking, and I know that the research in this has been limited already, but I believe most of it has been done with that strep, the group A strep. But, one of the things that really jumped out at me in your book was even something as simple as a yeast overgrowth, right? And I think we think of mold, but even, and mold can be very significant and severe, but even just yeast, that microbiome imbalance can be enough. Now, you talk about, and we do a lot of work with autoimmune, really finding all of the different underlying factors that can, that sort of perfect constellation that can sort of trip up the immune system. You mentioned genetic susceptibility, and I just want to ask, is there a genetic test? I think I know the answer to this question, but is there a genetic test that we can look at to say, like, oh, my child is predisposed? For example, like some of the SNPs that will give us a clue as to if somebody is going to respond much more severely to mold, as an example. Is there that kind of, do we know yet sort of what SNPs to be looking for?
Not really.
Okay.
And it's a great question. There are some HLA-B alleles that are similar to those you see in other vasculitis and other autoimmune diseases like HLA-B58, B32. Those can be abnormal, and that can be a sign. I'm actually working with Sharon Hausman-Cohen, who's the medical director of Intellex DNA. And the person who did the background work on this, a PhD by the name of Heather Way, in looking at more and more children with PANS and PANDAS. Their panel has a lot of kids with autism, and we all know there are many different SNPs that affect our children on the autistic spectrum. But we're looking for the ones that may really affect the children with PANS and PANDAS. Nothing concrete yet, but certainly tumor necrosis factor alpha, genetic defects that affect that may be abnormal in these kids. But the big thing we do know is that at least 64% of children with PANS or PANDAS have a first-degree relative with some form of autoimmune disease. So if you have a family history, a mom with thyroiditis, a dad with diabetes, a grandparent with rheumatic fever, all of those, and I've had lots of kids with all of those, then this is even more likely.
So then would you say, we point to the infection as the big trigger, but really it's likely that the infection was the proverbial straw that broke the camel's back. Would you agree? Because the terrain, we have lots of kids with strep who don't necessarily develop this. Thank goodness that this isn't something, already 1 in 200, if it's that low, is way too much. But it seems that the terrain has to be already in a fairly compromised place, whether that be from exposure to toxins, maybe microbiome imbalances, other low-lying infections, such as when you get this tipping factor of like the infection that pushed us over the edge. So Correct. It's a little bit, Dr. Naisha Winters always talks about you can't have cancer growth in a healthy body. I would imagine of an infection that pushes one into this kind of an autoimmune is starting off from a compromised place, whether we recognize it or not.
Absolutely. And the converse of that is that most of the children with this disorder, like my own son, have several different triggers. It may start out as one, it may start out as strep. And then like, oh my gosh, he has viruses, he has mold, he has yeast, he has, Bartonella, whatever it is. No, he has a dysregulated immune system. We need to provide all the foundational pieces. And I always talk about it as a 3-pronged approach. It's one, treating the symptom. So we want to help them sleep if nobody in the house is sleeping. We want them not to wet the bed every night. We want them not to have intrusive thoughts. So nutraceutically, naturally, I will start with treating the symptom that's most impairing the child and the family. The second thing is figuring out what is and treating the underlying trigger. So it may be strep, but More often, it's one of the other things. So, and I'm figuring out what that is, not just by lab testing, but really by history and physical exam. And then the
Right.
third piece that is often forgotten, or in conventional medicine, in the few docs that do believe in it, they think it's ibuprofen, steroids, or IVIG, and that's it. You know,
Right.
we need to treat the immune system, and that
Yeah.
certainly is nutrition.
Yeah.
I mean, it should be a good nutritive diet. Sometimes that's hard to start with the restrictive eating disorder on the first day,
Right.
but nutritional supplements, etc., to calm down that inflamed immune system.
Right. Absolutely. This is just a side note, but why do you think it is that the medical community has such a hard time with this, and that so many doctors conventionally are still either don't even believe it exists, or I guess let's even go to that. I mean, if at least if they believe it exists, they might, I mean, we might disagree about the path to healing, which it makes sense, but just dismissing it. What do you think is at the root of that?
I think it's a great question, and I think it's multifactorial, as most of those great questions are. I think one is what I said earlier, is that it was named Pandas,
Yeah.
and that became kind of kitschy, and
Right.
and rather than naming it a disease name. I think
Right.
number two, because in the general population it's about 1 in 200 children, physicians don't really recognize that a strep infection can cause this, because they see so many other strep infections that do not.
Yeah.
And I think number three is because it is a very, very complicated
Yeah.
thing to wrap your head around. And especially in pediatric, it's a volume business. And
Yeah.
so even just describing it to you, it takes me, 10 minutes, let alone treating it and supporting the family and writing the letters to get fluid access in and out of school while they're
Yeah.
getting better. All of those things make it very controversial. And then I think the last thing is, for the last 30 years as physicians, we've been reminded that antibiotics are not good for our gut. We shouldn't just be putting kids on antibiotics for every ear infection and cold that they come across, because 80% of them of ear infections are viral, and all of colds are. But pediatricians were doing so many antibiotics, and so our governing bodies were beating us down. You got to stop using all the antibiotics. And then here comes Pandas saying, no, you got to use antibiotics, and you got to
Right.
use it for 3 or 4 weeks.
Yeah.
And part of my point is, yes, we can use antibiotics, but we really need to talk more about herbals, because although I do use antibiotics early on, herbals are such a part of my treatment and so much more healing than just the killing of an antibiotic. So,
Absolutely. Absolutely. Um, I want to talk about, so we've got, I love this kind of three-part approach where you're really like supporting the family and the child to address the most pressing sort of life interrupting symptoms, while identifying and eradicating whatever trigger there is, while also supporting the immune system. And a lot of these underlying factors, and we think about sort of the terrain that allows one to tip into a situation like this, are things that we as functional nutrition professionals are dealing with on the daily, whether
exactly.
that's gut dysbiosis, even hidden gut infections, the diet obviously bringing down levels of inflammation, identifying and rooting out sources of toxicity, supporting those elimination pathways. I mean, the list goes on and on. This kind of a situation is both very complex, and there really is a medical component that is required. So it's something that we really want to be partnering with medical professionals on, unless if one who is listening or in the audience is licensed, that's a different story. But if not, really important opportunity to be partnering. Now,
And
just kind
I
of starting
partner,
from.
I apologize, and I
Oh
partner
yeah,
with
no.
dietitian and nutritionists. I mean, I used to, until 2 weeks ago, had a huge practice, and now I've gone back to my roots where it's just me. But I've kept with me the dietitian that I've worked with for 25 years, and a health coach, because it's complicated stuff. And I don't embody even all of the knowledge that I need for this. So I'm a big believer in it takes a village, and nutritionists need to be a big part of this healing in these kids. So it's a two-way street. It's not just you needing somebody that can prescribe. It's me needing somebody who can do all of the other work with me.
Well, putting ourselves just in the shoes of that nutrition professional, one of the things that happens oftentimes, and it's really interesting that you mentioned, like, the family member with autoimmunity. I will tell you, in my practice where I specialize in autoimmunity, not every client, but the typical would be mom comes to work with me. We're dealing with autoimmune. And then I become sort of the person that she wants to ask questions of. Sometimes spouse comes, often children end up coming through. So it's very common for us to be in this situation where a mom is sort of panicking, like this thing is going on with my child, and we're not in a position to diagnose. But you've just given us some really important questions to be asking. That handwriting piece I know is a really big one. And that's something, not being diagnostic, but, for practitioners in the audience, if you're hearing one of your clients describe their child having this acute, really remarkable onset of some of these symptoms, and I think that's a really good, simple question to ask, is about the handwriting. I want to talk all about partnering with a medical provider in a moment, but before we get there, let's start with diet, because diet is such an integral piece and such an important, it can be a really tricky, particularly tricky if part of things, if eating disorder is an aspect of what has just been triggered. So can you help us navigate that? And let's maybe start off with, do you have kind of a baseline style or baseline diet that then you customize and that you would like to, but then how do you navigate with these really tricky scenarios when part of the presentation is this extreme pickiness around food?
Right. So first it starts with knowing where they're coming from. Okay, because, as I said, at least 20% in our practice, over 35% have a restrictive eating disorder. So it's not your classic anorexia. It's more of either a fear of contamination or a fear of choking or wanting to eat only white food or purple food or whatever it is. It's a much more OCD eating disorder.
Right.
And so first, I want to see what the child is eating all the time. See where they are. And I want to find at least one thing that I can hook them with or change. For instance, if their diet is full of dairy and cow's milk or other animal milk, I'll really start to talk to them about, let's pull some of that back, because that can be a problem on many levels. We just wrote an article on cerebral folate deficiency in children with PANS and Pandas, and those kids need to be 100% off dairy. But my ideal would be to get them to what I would call an anti-inflammatory diet, a modified paleo diet. Sometimes a modified keto diet, a Mediterranean diet, whatever term in there you want to use. But I find that, one, they're bereft of protein, most of these kids. And so I want to find a way to get good protein in, especially early in the day, because a lot of these kids have brain fog, processing issues, may have an abrupt onset of even ADD. So I want to get good protein in the morning in any way that I can. The second thing is I want to promote vegetables and fruits as much as I can, and good fats. And so I talk to the families about that. I absolutely get them off all, as much as possible, additives, preservatives, colorings, dyes, etc. And I talk about a real whole food diet, nothing with a barcode. All real food. Do I get that there at the first visit? Absolutely not. But it may be as simple as, okay, you got no protein in your diet, let's add that. You're getting dairy all day long, let's pull back on that. You have absolutely no veggies, how and why, where can we add that? And depending on the age of the child, bringing them in as part of their contract, and I talk about building the foundation of a house. We want your house to get better. We want to build it as beautifully and as strong as we can. But if your house doesn't have a good foundation, it's going to collapse. So, people come to me as a physician and they want that antibiotic or they want that IVIG, and that's going to fix it. That's going to be the thing. And, I've had 4 or 5 people at least in the last few months say, I heard you were the diet doctor and I wasn't ready to do the diet, so I didn't come. Because it has to be part of what we do. And then as we move along and as they get better, I try to reinforce good diets. And I have to say very proudly that, my son to this day is now 26, getting his PhD, and he has the best diet of any 26-year-old I've ever seen, and knows the fundamental reasons why. And so even if they're not doing at that time, I remind parents, show them, walk the walk, just don't talk the talk. You got to go have your donut. Go to Dunkin' Donuts on your way to work. Don't put it in your pantry, or whatever it is. And reinforcing that with the whole family. So it's not this sick kid has to do this special diet. No, this is a healthy anti-inflammatory diet for everybody.
So you've really answered one of my next questions, which is when do you bring this into the conversation? And it sounds like you're bringing this in really from the onset, even if you recognizing that it's going to be a journey getting them from wherever they are. And I think that's a really helpful distinction when we think of the restrictions around the eating, that it can be something like only eating, as you said, purple foods or white foods, or, I've definitely seen in my own practice that like fear of contamination. This is really manifesting in a very different way than what we classically think of as eating disorder. So I think that's a really helpful distinction. And I also really like that you're taking them where they're at and then just sort of doing that little tweak with each time you're seeing them. So that actually also helps to understand, from the nutrition professional have an important role really from day one in this process, even if we're talking just at the most basic about manipulating the diet.
Exactly.
That's
and
really,
and the dietitian that I work with, Vicki Koblener, either she sees them first and gets them started on some, because my waiting list is longer, and gets them started on some nutritional supplements and dietary changes. Or if they've seen me first, then I say, hey, you have to see Vicki as part of this. So you, mom, learn what needs to be done. Even if you can't implement it yet, you know where we're headed.
Absolutely. Absolutely. And are you also a believer in doing this as a whole family, so that it's not just the child that we're supporting, but really an opportunity to recalibrate the entire family's diet? Yes, I think
absolutely,
that can be a powerful and hidden gift and silver lining inside some of these really complex situations, as it can be a benefit to the whole family gets to benefit. That's actually always something in my practice. I always say, this is not just about your child. Yeah. In fact, it's got to be the whole family in order for this to be successful.
Absolutely. So. And that one point on that is that often both parents are not together on this, on any of this, on how to treat it, on what it is, on, any of it. And certainly often not together on diet. When they are, it's great. But I do require both parents to be present. It doesn't always happen. But if the father is not there, and it's usually, I'm not trying to stereotype it at all, but that's the usual. If they're not there, then I ask, where does dad sit with this? Where does, where does he come in? And I try to involve him in the next visit, or I say to the families all the time, have dad call me. Because I don't want, this is a very stressful disease for these families. And I don't want these dietary changes or the herbs or the nutraceuticals or whatever I'm recommending to be another point of contention between mom and dad. So I'm also very conscious of trying to get them all together, but honoring that one person may not be anywhere near to even thinking this way, let alone supporting the other parent in doing it. So
you mentioned something earlier when talking about the kids, as you said, this might be part of their contract. Can you speak more to that? Because I love this idea. You got me thinking, I need to be having clients sign contracts. I love this idea. And is that so talk to us more about what that is.
Yeah, I've done it all the time. Did it with my own son, talked to all of my patients about it. Now, I think, first of all, if you're a parent, you're the parent. In my way of thinking, you're still in charge. You are making the decision. So a 3-year-old or a 7-year-old doesn't get to decide what you're buying at the grocery store. They're not driving. So you get to bring home what the food is. So that's a little bit different than the 9-year-old or 11-year-old that's going to other friends' houses, that's getting, lunch taken to school but doesn't eat it and eats her friend's lunch instead, or the 16-year-old that's driving themselves around. Those kids you specifically need to get on board. And I usually say, what's one food you really like, and what's one thing you really can't stand ever thinking about having? And then I work within the parameters of that. And let's say I really want to get them off dairy. Let's say that's what it is. I'll say, okay, you need to be 100%. And with dairy, I'll see if I can get to 6 weeks, but I'll at least do 3 weeks. Yeah. I'll say 100%. You just gotta, you and I are going to agree. I won't give you 20 pills to take. I'll only give you 10, because I wasn't going to give him 20 anyway. I was going to give him 10, but let's just say, I may fudge it a little bit, but I'll only give you 10. Or I'll allow you to do this if you agree 100% to be dairy free for the next 3 weeks. And then you come back to me and tell me. And more times than not, whatever it is, because remember, kids crave that which they're most sensitive to. So if they're eating that much of something, it could be sugars and carbs, then they're probably yeasty or moldy. If it's dairy, they may have cerebral folate deficiency, or they may have endomorphins that are causing their brain to desire that. But if you take that away for a time, initially, and I remind everybody, you may feel worse. It's like a heroin addict. You may go through that die-off. But give it a few days, sometimes a week, and then I bet you'll feel better. And if you don't, you can go back and tell me I was crazy, and then we'll move on to something else. And 90% of the time, at least, if they do that, they come back admitting, maybe I feel a little bit better. Not enough to continue being 100%, and then I'll say, okay, well, you have this one defect where you have to stay 100%. Can you do it for another 3 months? So I do it in periods of time that the kids can digest. And at the same time, I think the best form of parenting is bribery. So
I love it.
I do. So, we bribe in our office, but I say to parents, they do it for 3 weeks and they want the Lego set, or they want the new app for their iPhone, or they want an extra half hour on the weekend, with their video games or whatever it may be. That's what they get if they've kept their end of the bargain, because we have to give them something too. So,
yeah. Oh, this is such helpful advice. Now, when it comes to some of the other layers that are part of this, and I'm thinking of some of those more foundational pieces, like the gut healing, like the, detoxification, like just some of these lower lying sort of systemic issues that we really want to be supporting. At what point are you addressing those? Are you bringing those right out the gate, or are you really focusing first, let's get symptoms under control, let's identify this trigger and get that under control, and then bringing in some of those more foundational pieces? Are you trying to do it concurrently?
In my opinion, the gut is not the second brain, it's the first brain. And so if you're not addressing the gut, you're not addressing the brain. So I'm at the very least using oral anti-inflammatories, colostrum, oral immunoglobulins, turmeric, curcumin, those sorts of things as my anti-inflammatories that will also be supporting their gut. Then if I often do a Woods lamp exam, which, Woods lamp is that UV light that the skin changes color to a yellow orange if the child has what medically is called tinea versicolor, which is just yeast of a different color. So if I see that on exam, I don't even need a test to tell me I need to start treating that. So I will start doing all of those things and the beginnings of nutritional pieces very early on. And then a lot of my testing early on is not just strep and inflammatory markers and all of that. It's also either a urine organic acid or, depending on their gut symptoms, a stool test, and then using that data at the follow-up visit to build on that and do even more for the gut as necessary.
Hey, clinicians, do you ever wonder what really happens behind the scenes when top practitioners tackle complex health cases? Well, you can find out at Restorative Wellness Solutions' upcoming Clinical Success Showcase, a free 4-day virtual event starting on January 27th. Get a first-hand look under the hood as leading clinicians walk you through their most challenging cases, showing you exactly how they uncover things from hidden thyroid imbalances, supporting children's mental and emotional well-being naturally, optimize metabolic health, and restore fertility in complex cases. No theory here. We are going for real cases, real protocols, and real results. Each session includes step-by-step analysis of symptom intake, lab work, and a detailed discussion around how each practitioner crafted a targeted, personalized protocol for their client. There will also be an opportunity for live Q&A where you'll have the opportunity to get your questions answered. Join us daily from 12 to 2:30 p.m. Eastern, January 27th through the 30th, to master the clinical strategies that get breakthrough results. Get your free pass to this virtual event now. Simply head to the show notes and click the Clinical Success Showcase link. I'll see you there. There's again, so many things I want to follow up on here. I want to make sure we have this really important conversation about how do we find medical providers who can support these children alongside us if we are non-licensed practitioners, and the people sort of sometimes discovering this. Every once in a while, you'll have somebody who has had a diagnosis come in and be looking for that nutritional help. I think it's more common to be the other side, where they're just they're sort of panicking and asking all the people they know that they trust, and then needing to point them in that direction. And since this is such since it's so complex and not believed, or for all the reasons that we've already talked about, by the conventional medical world, it's not easy to find somebody. How do we find that person? And then how do we best collaborate with them?
Right. I think there are several resources. First, I just came from a conference called MAPS, Medical Academy of Pediatrics and Special Needs. It's for all children with chronic illness. And by the way, one thing that I forgot to say is 1 in 2 children now have a chronic illness of some sort.
Oh my gosh, that's so distressing.
All of those have an autoimmune underpinning, if not frank autoimmune disease. So medmaps.org has, and it's medmaps.org, has a provider directory, and those are people that should be trained in PANS and Pandas. Not all of them will be, but they're very much trained in functional medicine. And by the way, nutritionists, dietitians, health coaches are all welcome to come to those conferences, as well as join the fellowship. The second is aspire.care. aspire.care. That's a group. Sue Sweeto and I are both on the board. Gabriella True is the president. And that's a group dedicated just to pandas, and they too have a provider directory that I think is very good. In both of those groups, you will get functional medicine providers that are very well trained in autoimmune disease and in post-infectious problems. Now, there is also the Pandas Physician Network, Pandas PPN, and that has a very good group of physicians. Many of them don't know what a good diet is to save their life. I mean, the practice I was in, I remember when I first went to dinner with them, and they were talking about how their kids were eating Oreos and chocolate milk for dinner all the time because they couldn't fight with them about having healthier diets. So the Pandas PPN is another resource, but you have to be sure that as a nutritionist or a dietitian that they may not be working against you, even though they may be helping the family. And then the last I want to say, one of the reasons I wrote the book so that parents could understand it too, and not just for physicians, because there are also other excellent books out there. I mean, Scott Antoine just wrote a comprehensive guide that's wonderful. But I wrote this so that parents could understand it and take it to their pediatrician and say, look at this case. You know, Matt's case is just like my son. And look what helped him. And as a nutritionist, if the parent says, you know, I have a provider that's sort of listening, you know, go to that primary care and say, look, I'm not telling you what to do, but, you know, I've worked with this doctor, you know, Dr. O'Hara, and, you know, I can vouch for her book. And maybe if you just give a little bit longer course of azithromycin, we could see what would happen together. And a lot of primary care providers are willing to do that. And I mention azithro because, at least in my area, azithromycin, strep is sensitive to it, covers mycoplasma. It's one of the first lines for Borrelia, Babesia, or Bartonella. It also can be helpful in COVID. COVID's opened up a whole new can of worms here that, you know, we haven't even addressed. But I think there are primary care providers that are willing to listen. And if they're willing to do one thing, there is so much that you know, non-prescribing providers can augment and treat foundationally in addition to them.
Well, it's another thing that I love about your book is the long list of case studies. Normally you get like one or two little sort of examples or little anecdotes here and there in chapters, but you have, I feel like almost half of your book is dedicated to really comprehensive case studies. So that's a fantastic resource for parents and practitioners alike. Is there any guidance that you would give? I love the, you know, if the sort of that door is open, sort of gently, you know, helping it through. I think having this book, you know, being as knowledgeable as you can, and just you know, asking some really good questions. Have you seen any, you know, you've worked at length with dietitians, nutritionists. What would you say are some of the best practices of these nutrition professionals in collaborating? Like, what is it that you love most about collaborating with them, and what would be some things that would send you running? I think it's important we have the conversation because sometimes we do things we don't realize, and I want to make sure folks know what could be a major red flag.
The only thing that makes me run from any professional is a protocol. This is an N of 1 in front of you. That N of 1 is your clinical case study. And that child should be treated differently than every other child that you've seen. Now, you have certain things that you'll always use, certain ways that you'll always do things. We all do that. But if every single child gets treated the same way, and if every child I send to you as a nutritionist gets put on a low oxalate diet or gets put on, you know, no matter where they come from, I'm not going to call you again.
Yeah.
And that goes for every gastroenterologist, neurologist. If they're doing the same thing on every kid and 100%. Not thinking about it, no way. Other than that, I work better with a lot of dietitians and work better with dietitians and nutritionists than I do with most MDs. So I never have a problem with that. It's the MDs that are the ones that are a little bit harder to work with. And I think, if you're approaching a physician as a dietitian or a nutritionist, and I do this with physicians too, not to, and if there are any physicians on this, I love you all dearly, but we do tend to have egos. And I ingratiate myself a little bit, and I say, I understand where you're coming from, but I have a lot of experience with this and I'm happy to send you several resources if you'd like me to. I'm just asking you to think about it, not being dogmatic, not being, and if they say, I absolutely won't, then I often say, well, do I have your permission to try a couple of things with this family? In that way, well, this family has asked me to work with them, and I understand you're not on board with this, but could we agree to disagree? And so I often frame things in that way. And it works most of the time. And I know it's different for me because I do have those initials after my name. But when I work with Vicky, I say all the time, it's only the initials after her name that make us any different. She knows as much as I do about this disease. And, it's important that we at least try to reach out to these physicians, I think, because they need to understand that they're not the only intelligent people in the room. And learn to listen. My big motto is, if you listen, they will come. And many physicians, because it's volume business, have stopped listening. So if you get turned off within the first 5 seconds, don't try to push too hard because, it's not going to go well. If they're not even listening in your first 5 minutes of talking, forget it. So.
Well, I love this so much, and I love the N of one, and it was so funny. I knew I liked you for so many reasons, and they're just stacking up. But we're always saying, we don't teach protocols. We teach the clinical thinking, the critical thinking, the investigation for exactly the reason that you say, because there is no such thing as a diet or a protocol that works for all of the people. That's why we love working with lab tests as so much, is because it helps us get really specific. And to that end, I see Ellen has a question here about food sensitivity testing. Is that a piece that you will bring in to help kind of dial in? We can take out some of the big heavy hitters. Dairy, I'm going to assume gluten is another one. The sugar, the processed foods, the food dyes. But what, we see people who have sensitivities to cashews or, lettuce. So these things seem absolutely very random. So, how is that a piece of the process that you sometimes bring in?
It can be. And one thing I want to say is that as a girl from West Virginia, I walk around with my mouth open at the cost of everything, including me. Yeah. And so I try very, very hard to keep the cost down for families. And also, as I said before, kids crave that which they're most sensitive to. Or if a family comes in and tells you every time he has cashews, his behavior goes through the roof, or every time he has meat, he has diarrhea, or, you don't need a test to tell yourself or that family, okay, that's its sensitivity. I do use it. I use it also to help prove to families they have gut permeability or a leaky gut. Because when they have multiple food sensitivities, all of one plus, it's not about the food, it's about the gut. So I will use it to prove to families they need to do X, Y, or Z in removing it. I need to prove to families that it's a leaky gut problem. And then I'll use it as I may need to within the parameters of their finances.
Right. That makes a ton of sense. Ali has a really interesting question here. If an adult potentially had PANS or Pandas as a child, but it was undiagnosed, which we know happens a lot, how would the symptoms then present? Is it similar as a child, or do they manifest differently? And then what is the clinical approach? Is it similar?
It's
That's
a
a great
great
question.
Great question. So there's several facets to this, and I know I give a lot of long-winded answers. I'm very verbose,
I
but
love your
anyway,
answers.
we used to say that this was only a disease of pediatrics, and that's because the blood-brain barrier starts to close at adolescence. So a lot of kids that get this at age 7 should grow out of it at puberty. But then the blood-brain barrier should fully close between the ages of 21 and 25. But because we live in a toxic world with so many toxins, chemicals in our environments, our blood-brain barriers in all of us have been breaking down. And so that allows the entry of these antibodies into the brain. And we're seeing a lot more young people, young adults, with this disorder that we can't even find anything in childhood, even with great detective work. But I think the things that happen there that are different, the brain fog is a much bigger piece of it. They may just have that, all of a sudden the slow processing speed, sort of thinking of the things that we're calling long COVID.
Right.
About 25% of the people, it'll be this post-infectious syndrome that we really need to be doing more to do this 3-pronged approach. So that's one way. The second is the older they are, the more likely they are to have actual hallucinations, psychosis, almost a schizophrenic presentation. And that's about 10% of kids, but it's double that in the young adults and adults. And then it really depends also on what the trigger is in the adult. If the trigger was Bartonella, it may be raging and those stretch marks. If the trigger was Babesia, it may be, night sweats and the dysautonomia, the dysregulation of the autonomic or automatic nervous system. If it's mold, it's going to be like ice pick sensations plus the brain fog. So it's also about what was the trigger. So the triggers may present similarly in adults to children, but great question. And yes, definitely see it in adults. And I think I've answered it now.
You mentioned the COVID connection, and I realized we could probably do an entire conversation just on that. But I'm wondering, is there a parallel here with long COVID?
Absolutely.
Yeah.
Yeah, and I think especially with our Lyme-induced, what we know is that COVID, whether it be the infection or the injection or just exposure to one of the two, it is reactivating previous EBV, mono, CMV, herpes. It's reactivating Borrelia, Bartonella, Babesia. It's reactivating other infections that we thought we had thoroughly treated. So absolutely. And that's why whenever I hear COVID's in the background, I'm adding more antioxidant, antiviral support, even if their trigger in that moment may have been strep, they're going to have something else in the background.
I'm going to ask you a question that I always get asked, and I hate this question. So I apologize in advance for asking it because it's an extremely annoying question, but I know there's people wondering it. So I'm going to ask it, which is the timeline, right? I'm sure when families come to you with a child in such distress, they want to know how long is this going to take? And so knowing that every case is really unique. Do you see an average? I think about, for example, gut infections, we're thinking, especially with children, they come back so quickly within a couple months sometimes. But something like mold can be a much longer, you're sort of preparing the family, like we're tucking in here for a while. When we're talking about pandas, what is our timeline? That you're just the range, recognizing that there is no in 3 weeks we'll be done.
Yeah. It's never 3 weeks. And I have to say that even when it is, what people are missing is the prophylactic treatment to prevent the next recurrence, because the second, third, and fourth are worse. So that's why I'm using so many herbals to prevent it, because I don't want them on prolonged antibiotics.
Right.
Penicillin is twice a day, every day, and you miss one dose, you're not covered for 3 days for strep. Anyway, but when it's just strep, it can be just a couple of months. Mycoplasma is several months. When it's Borrelia, Babesia, Bartonella, it's a minimum of 9 months, often 2 years. When it's mold, it's at least a year, often more, depending on how well and how much they can remediate. If they can't remediate, I have a lot of families that can't get their landlords to do anything, can't move, can't remediate, can't afford to do it. Then it can be done, even if they can't remediate it, but then it will take longer. So it does depend on the age of the child. The younger, they'll get better faster. It's why I don't take care of adults. Anyway, that's one of the many reasons. But, it's how old they are, how long they've been sick, and what the trigger is. But I never tell anybody weeks. It's months at a minimum. And I always say, this is a marathon, not a sprint.
Yeah. Nobody wants to hear it, but it is the truth. Now, in terms of symptom, when you're bringing in some of these interventions to help with the symptoms, do you find some of the strategies you're using, you're able to get some, at least momentum going within the first few weeks, just to alleviate some of the more extreme pressures?
Absolutely. I mean, they do an appointment with me. I get them on something. Turmeric has been a game changer for me. In particular forms, I have one on the line that I started, just really can nip it in the bud. I see that if they're not on SSRIs with 5-HTP. With ticks, I see it with magnesium. So that's why I'm really looking at what that symptom is and trying to get a nutraceutical in there that can treat it, because that's what'll change fastest. Because remember, for me, I have such a long waiting list. I'm getting the really sick ones. They didn't just get strep 6 weeks ago. They may have had this for 6 months, 6 years. So I'm getting at that symptom first, and that immune modulating, antihistamines, bioflavonoids, can really make a difference. But yes, I'm looking for what can I do? And then one of my allied staff, my health coach or the dietitian I work with, will usually have an appointment a week to 2 weeks after, see how they're doing, make sure they're getting some traction. If they're not, then maybe switch it up just a little bit. And then I see them after 6 weeks, and then almost all of them have something that's gotten better. And then I can say, okay, we're doing this way. And I also like, in addition to that bribery and contract, I also like grading things on like a scale of 0 to 10,
Yes.
And I will tell parents, where do you think your child's is right now? Oh, it's a 10. It's a 12 out of 10. It's a 50 out of 10. And then when they come back, I'll ask them again, maybe it's an 8 out of 10. That's progress, So reminding them, because you as the practitioner have the grandmother effect or grandfather effect, where you're not seeing them all the time, and you can see that benefit where the parents are entrenched with it and maybe missing the more subtle things unless you're pointing them out.
Yeah. Oh my goodness. Dr. O'Hara, thank you for all that you do. You have an amazing membership. I'm going to put the link. So for those of you who are here live, we have a link here that's going to give you a discount. And then for those of you who are listening to the recording, we'll make sure to include this in the show notes. Why don't you share a little bit about, because it's an incredible resource. So get the book. That's just a no-brainer. And then tell us a little bit about what's in the membership. It's both for practitioners, but also for parents, right?
Right. It's an annual membership. And what's in there now is my treatment flow chart, which is a functional medicine flow chart. If this, then this. If that didn't work, then this. So that big thing. Then there's 6 lectures on mold, on neurotherapy, on Lyme, on PANS, on Pandas. and then one that's just case studies. Then there are now over 40 short videos, 2 to 5 minutes, talking about everything. Some are just on certain nutraceuticals, some are on herbals, some are herbals for this or herbals for this, some are how I do a physical exam, looking at choreiform movements or the Woods lamp or whatever it is. Some is how I talk to parents. Some is tough nuts. So there's about 40 of those videos. And then for the last 2 years, I've had monthly teachings, and all of those are recorded, and you get all of the ones that are already recorded. Plus, every month going forward, we address a different topic. Because we've addressed all the topics with me just lecturing, I'm done with that. And now we do case studies. Either you can bring one to me and we'll all talk about it, or I bring one if nobody has one, and we talk about that. And we interact for about 20, 25 minutes, and then we have a Q&A, and it's all live and recorded. And then you also get access to my nutraceutical line, which is a small set of herbals and nutraceuticals that I have really tested that I think are helpful for these kids. And it's just sort of a one-stop shop for the Pandas stuff. That may help to send families there. For instance, there's bundles. This is the anti-inflammatory bundle. This is the Borrelia bundle, etc. So it's all of that. And in addition, you know, I don't advertise this too much, but I'll tell you guys, any member can have a 15-minute free consult with me. You know, I'll do it as frequently as 4 times a year. And that's part of it. If you can't be on the live Q&A or you want to talk privately, you know, I also provide that to members. So
that is so generous. Thank you so much. And as I was telling you before, our community loves case studies. And I think the fact that we can bring case studies, that is a huge draw. So for any of you who see clients, you know, who have families in your practice, who deal with autoimmunity, this is something that you're going to bump into at some time. And it's an incredible resource. Your book is incredible. The work that you're doing is wonderful. I am so grateful to you coming here tonight and spending this time with us. So inspiring and hopeful. And yes, as I said, thank you so much for what you do.
No, thank you for inviting me. And thanks to all who are listening live or listening to the recording for doing what you're doing. Because it does take a village and it takes all of us. And thank you.